Hello everyone and welcome. I am Sri Devi Sira Mahalingappa, President at British Indian Psychiatric Association. I'm currently working as a consultant psychiatrist at the South London and Maudsley NHS Foundation Trust. I was trained in India. I did a diploma in psychiatry at the National Institute of Mental Health and Neurosciences, also known as NIMHANS in Bangalore. I've been working in UK since 2005. I also worked in Australia for 2 years during COVID time. Now I'm back in the UK. I have been involved in BIPA in various roles since 2010 and I'm very pleased with the progress that we have made so far. For those of you who are new to British Indian Psychiatric Association, also known as BIPA, we are a charity based in the UK. We were established in 1995 and currently we have more than 700 members and we are continuing to grow. We are also one of the largest psychiatrist diaspora organization in the UK. Our aim is to support our members and also other psychiatrists and wider community. So if you would like to get involved in our activities, then please do contact us. We would be delighted to work with you. Our aim is to provide free CPD events for everyone. We are a small charity and we would be very grateful if you are able to make any donation that will help us to run these events for free in future. Please do make a donation using the link on our website. I'm really very grateful for our team support, especially our inspiring treasurer, Dr. Shweta Mittal and Dr. Vatsal Zapadia, who have been working very hard to make these events happen. Thank you all. Today, we are incredibly fortunate to have with us Professor Matcheri Keshavan. Professor Keshavan is the Stanley R. Cobb Professor and Academic Head of Psychiatry at Beth Israel Deaconess Medical Center and Massachusetts Mental Health Center, Harvard Medical School. Professor Keshavan has extensive experience working in many institutions around the world, including NIMHANS, one of the premier institute in India, and then at the Maudsley Hospital in the UK, and also in other countries, and now at Harvard. Professor Keshavan is a well-known researcher and a clinician recognized for his extensive work in the neurobiology of psychosis. His impressive career includes over 700 publications, and he has received numerous awards for his contribution to psychiatry, including the Gaskell Gold Medal and the National Alliance for Mentally Ill Research Award. He also serves as Editor-in-Chief of Schizophrenia Research. His research focuses on key areas like the neurodevelopmental basis of schizophrenia, neuroimaging, biomarkers, and early intervention. Beyond his research, he is deeply committed to medical education, teaching Harvard Medical School students and residents. I personally heard Professor Keshavan's lecture about 12 years ago and I still remember it so well. I'm sure you will enjoy and learn a lot from his sessions today. Without further ado, I will hand it over to Professor Keshavan to begin the session. Thank you very much, Professor Keshavan.
Okay, thank you very much. And good afternoon and good evening to everyone wherever you're listening from. So I'm going to talk to you this afternoon about what I have learned about schizophrenia over the last 40 plus years of my career. And it's indeed an honor and a joy to speak to the British Indian Psychiatric Association, BIPA. And since I trained in Britain myself and I came from India, so I feel a little bit like I belong to you already. This slide really gives you a little bit of my journey. I initially trained in Mysore Medical College and then went to my initial psychiatry training in Bangalore at the National Institute of Mental Health and Neurosciences, which is the sketch on the top left of this slide. And then I had a brief stint of about 2 years at the Maudsley Hospital, London, an Institute of Psychiatry. And subsequent to that, I moved to the United States and worked in Pittsburgh, Detroit, and over the last 15 years at the Harvard Medical School, and Beth Deaconess Medical Center. And I have continued to learn a tremendous amount of psychiatry through these, what you might call transcultural residency training across 3 different continents, and especially how to understand and take care of of schizophrenia, a complex psychiatric condition. Just briefly, I want to say what I learned early in my training on schizophrenia, both in medical school and then subsequently during my psychiatry residency training at NIMHANS in Bangalore. Those days in the 1970s, the thinking was that schizophrenia is caused by too much dopamine in the brain. And we still didn't know whether it's a functional brain disease or an organic brain disease. So there was all this big debate going on. The general thinking was that schizophrenia may be a neurodegenerative disorder, maybe a progressive illness, consistent with the original name of this illness, which used to be called dementia precox. And also, it was recognized that there is a strong hereditary component and that there might be a single gene. This is what we thought in the 1970s and early 1980s. What I'm going to tell you in the rest of this lecture is that the thinking in the field has changed in every one of these areas about whether dopamine is the main problem, whether it's a brain disease, whether it's a progressive brain disease, and whether there is a single gene, and so on. Very briefly, you all know schizophrenia is a common condition, about half to 1% of the general population. It's highly disabling, one of the most highly disabling in all of medicine, about less than 10% being employed during their lifetime. It's also a disease that has a high mortality as well as morbidity. It shortens life by about 15 years. And it's highly expensive disease. It's in the United States itself. The cost of the illness, both direct and indirect, amounts to about $250 billion. So, given that as the background for the importance of this illness, let's think about how we understand it. When I was in medical school and then residency, it used to be said schizophrenia, like lupus, like multiple sclerosis, is a disease of theories. There were too many theories. In all the other medical disorders, we have moved on and understood, beginning to understand the disease pathophysiology much more than what we have in schizophrenia. What in schizophrenia was the thinking, and to some extent continues to be so, is like the ancient Indian parable of a elephant in a dark room being groped by 6 blind Indian men. One who feels the trunk and says it's a spear. One who feels the um, ears and thinks it is a fan. One who feels the wall and thinks it is a wall, the body and feels it's a wall. One who feels the legs and says it's a tree trunk, and so on. So, depending on one's viewpoint, one's discipline or profession, one comes up with a different theory. And likewise, in schizophrenia, there have been theories that this is due to a schizophrenogenic mother. It used to be a popular theory even in my residency training days. And in the same time period, it was also a popular view that schizophrenia is a spiritual breakthrough, not a nervous breakdown. In fact, a British psychiatrist by name R.D. Laing proposed that viewpoint. It became quite famous at that time. Another psychiatrist, an American psychiatrist, Thomas Szasz, argued that schizophrenia is a social problem. It is a sane response to an insane world, is what he said. Around the same time, as I said earlier, we were thinking that schizophrenia is a dopamine problem, that there may be an immune mechanism, and it may be either degenerative or developmental. Although all those ideas existed, but we didn't know for sure. But thankfully, over the last 40, 50 years, a number of wrong theories are being disproved. But some of the more valid theories are getting more traction, including the developmental theory, the dopamine theory, and the autoimmune theory, and so on. So we'll talk a little bit about each of these as we go forward. Now, how did I get interested in schizophrenia? So I did some neurology to begin with and then went into psychiatry. My neurology professor, who wanted me to stay in neurology, said at least do some neurological research in psychiatry. And he said schizophrenia is a functional brain disease. So if you examine prefrontal neurological science, you will find that that will very clearly distinguish between organic psychosis and functional psychosis, and then you can write a paper. So I went and did this study with my friend Vikram Yaragani in Nimhans. It's a big mental hospital with about 1,000 patients. So we went 3 weekends in a row and did neurological exams on about 100 schizophrenia patients and 100 organic psychosis and 100 controls. Here is an example of a neurological sign where you scratch the palm like that, or the thenar eminence, and look at the chin, which twitches with that noxious stimulus. This is usually present in infants, but disappears by age 2. But in dementia and other organic psychosis, it reappears. This is what Professor Mani told me, and he said you should test it out in schizophrenia patients. So we went with the hypothesis that schizophrenia patients will not show this and that organic psychosis patients will show it. But lo and behold, what we found was that there was no difference between schizophrenia and organic mental disorders in regard to the prevalence of this soft neurological science called the palmomental reflex. Of course, healthy controls were positive about 13% of the time. So this really impressed upon me the importance of considering schizophrenia as a neurological disorder. And then we had a patient, was a lecturer in MHANS, and we used to have case conferences where both neurologists and psychiatrists got together once on a weekly basis and did case conferences on different cases. So here was a young woman who had been admitted with what appeared like a catatonic syndrome. She also had a little bit of fever, and she had neurological soft signs, palmomental reflex, glabular tap, increased blink rate. Neurologist said, this looks organic. You should really get her transferred to neurology and and do an LP and so on. So they did that, and everything turned out to be normal. And the psychiatrist, the wise um, senior consultant that we had, he said, no, of course, this is not organic. This is schizophrenia. And anyway, he gave her a course of ECT, and the catatonia dramatically responded, and patient was discharged, and she was lost to follow-up. The reason I present this case is that this was 1984, and 35 years later, my friend Urvaksh Mehta said, Dr. Keshavan, your patient who you saw 35 years ago has showed up back again with a recurrent relapsing schizophrenia. So she had been lost to follow up in Bangalore, but she was in another part of the country. And then went back and looked at my notes, and I had written all of these diagnostic possibilities, including the positive neurological signs. And we had made a diagnosis of um, so-called organic psychosis at that time, which time told us that this followed the classic pattern of schizophrenia over the course of time. So Urvak Mehta wrote this up as a paper a few years ago. And the reason I present this is like a 35-year follow-up of a single case where there was a diagnostic challenge. And again, kind of confirms the point that schizophrenia is really a neurological kind of illness, but unfortunately is still viewed in many circles as a functional psychosis. So since then, I made that as a part of my career to examine the neurobiology of schizophrenia. And one of the royal roads to understanding the brain is cognition. And we showed in a series of studies that schizophrenia is associated prominently with cognitive impairment, which begins early in the illness, even before the illness, during the prodromal and the premorbid phases of the illness. Impaired cognition is a important clue to altered brain structure and function. So this is what led us to a series of studies of neurological impairments in schizophrenia, and cognitive impairments in schizophrenia, and brain structural and functional alterations in this illness. So we showed we investigated a group of never previously treated antipsychotic naive first episode schizophrenia patients in Pittsburgh over a number of years, whom we followed up as well. And we showed that there is not only structural and functional brain loss, but also hippocampal overactivity and functional reductions in prefrontal activity, what we call what later came to be called hypofrontality. And that brings me to thinking about how these kind of structural and functional brain abnormalities might set in. And this is what brings us to understanding schizophrenia as a developmental disease. And so I will explain in this slide about how the brain develops and how that process of development might go wrong in this illness. As you see here, neurons are conceived at the time of conception. They proliferate, they sprout synapses, and the neurons migrate to the appropriate parts of the brain, and they prune out to make it more efficient. The unnecessary and redundant synapses are lost through a programmed synaptic elimination process. And then the neurons that are functioning are myelinated to make them more rapidly conducting. And that is the process called synaptic pruning. This actually leads to some reduction in the thickness of the cortex. As you see in the top right, that is the imaging animation based on hundreds of scans done at the NIMH by Paul Thompson and colleagues. In healthy individuals, as you move from childhood to adolescence and young adulthood, there is a progressive thinning of the cerebral cortex. As you see, those regions becoming progressively blue. The bluer it is, the thinner the region. The last brain regions to become pruned out is actually the prefrontal cortex. So there is a progressive neuronal maturation that happens beginning in the back regions of the brain and moving progressively forward to the frontal regions. So that's how the brain normally develops. And the pruning sets in the stage for the neurons to myelinate. Myelination is important for conduction. The more myelinated the neurons are, they conduct faster. So you need myelination. And this is another process that begins in childhood and particularly prominent in adolescence. And throughout life, we continue to myelinate our neurons. In the 1980s or 70s, Peter Huttenlocher showed that there is this kind of a synapse density reduction during adolescence in healthy individuals. And an important idea was developed in the early 1980s by Erwin Feinberg, who passed away recently. He said that schizophrenia may be related to a faulty synaptic pruning process during adolescence. He said that there may be too much pruning, too little pruning, or the wrong neurons being pruned out. But he said that we have no idea how to distinguish between these three possibilities. And he said that this may be due to a bug in the genetic program, something that is affecting the programming of the synaptic pruning process that may cause this illness. And dopamine may be involved, is what he said. Very, very influential paper, 1982-83. That is when it was published. Then we were very interested in this, and we wanted to look at the literature and see whether we could come up with an idea of further refining the Feinberg hypothesis. So we looked at structural imaging, functional imaging, spectroscopic, neurochemical imaging, electrophysiological studies of delta sleep, and also spectroscopic measurements of how much neurons are synthesized and turning over. And we showed, as we found, as we predicted, that normal adolescents there is a decrease in synapse density, decrease in cortical thickness, decreased prefrontal metabolism, decreased intensity of delta sleep, and decreased new neuronal membrane synthesis. And then when you look at what happens in schizophrenia, you have an exaggeration of all of these same processes. So based on that, we made the argument that it is an exaggeration of the synaptic pruning that happens during adolescence, as you see in that red line. So the neurons, which are like the forest in in the spring and fall, begin to look like very sparse, losing all their branches and leaves in the winter as you get into the young adulthood. But that process gets exaggerated in this illness. And that was actually supported by neuropathological studies. David Lewis, who was my colleague in Pittsburgh at that time, he published a very important paper showing that, as you will see in the bottom right, the neurons that of schizophrenia brains have too few synapses compared to the healthy brains. So there's some support for the synaptic pruning hypothesis that way. And even more recently, the question of why the or how synaptic pruning takes place in the brain became more and more clear. So not far from where I work in Harvard, a neuroscientist showed that pruning happens in the brain because there is a programmed elimination of synapses, and that is done by microglia. So what are the microglia doing there? Their job is to, fight bacteria from outside. So what Stefan et al. Found is that microglia, which are like the immune cells in the brain, they have double duty. When they are not fighting external bacteria, they have a housekeeping duty. And their job is to phagocytose the non-functioning redundant neuronal connections. And they do that by a series of proteins that are on their surface, which are the complement cascade, which really detects inactive synapses, which tell the microglia, eat me, and the microglia promptly engulfs and eliminates those synapses. This is how synaptic pruning process works. And you see that phytomicrograph of synapses being eliminated by the microglia, which have those red dots there, which are the complement proteins. I come back to schizophrenia. What is happening there is that there is loss of cortical tissue, especially gray matter, which may be a process related to excessive synaptic pruning and begins in the premorbid phase and declines further in the prodromal phase and continues after illness onset. And the Naples studies of the schizophrenia prodrome, which we've been part of over the years, has shown that individuals who progress to psychosis in the prodromal phase are the ones that show gray matter loss. And that continues, as Paul Thompson from the NIMH showed, that there is a further loss of gray matter and cortical thickness reductions during young adulthood in the first few years of the illness. So the net result of that is that there is a reduction in synapse density in schizophrenia, which is kind of the opposite of what you see in autism, where there may be too little pruning. But that's a separate story. And what does this excessive synaptic pruning do? As I said earlier, pruning is paralleled by synaptic the neuronal myelination. As we get older, there is more and more myelination of our neurons. And that is made possible by the, if you want to build highways in a highly, forested area, you need to trim trees out so that you can build the highways. So if the synaptic pruning doesn't happen appropriately, the building of the highways don't happen. And so that is what might lead to reduction of connectivity between different brain regions because myelination might be at fault. That brings us to the question of what might be happening neurochemically in this illness. As I said, as even going back to my medical student days, it was all dopamine. But what has become more and more clear over the last 2 to 3 decades is that the neurochemistry of schizophrenia is more complex than that. So if you think about how the brain works or develops, most of the neuronal proliferation and the pruning that happens is on glutamatergic neurons, which are the excitatory neurons on the pyramidal cells. And then there is another neurotransmitter that really grows into the brain during adolescence, which is dopaminergic neurons. Both dopamine and glutamate are excitatory neurotransmitters. So you might ask the question, adolescence is a period where there is a lot of glutamate and there is a lot of dopamine coming into the cortex as well. How come all teenagers are not developing psychosis? The answer to that is that there is an inhibitory neurotransmitter that also develops during childhood and adolescence, which kind of balances out the excitatory neurotransmitters like glutamate and dopamine. So there is a yin and a yang here, and which is why most of the teenagers do not develop psychosis. But a loss of balance of these excitatory and inhibitory connections might be what leads to the risk for psychiatric disorders, especially schizophrenia and bipolar disorder and so on. Yeah, there it is. And yeah. So that leads to us to understanding what might be happening in the neurochemistry of this illness. So there is the dopaminergic neurons, which come from the midbrain to the limbic regions, which are called the mesolimbic dopaminergic system. Too much of an activity of limbic dopaminergic system might cause psychosis. But that doesn't explain to us why people with schizophrenia have not only psychosis, but they also have negative symptoms and cognitive impairments. And to explain that, Danny Weinberger argued that there might be let me go back to that. Yeah, there might be a failure of another part of the dopaminergic system, which is the mesocortical dopaminergic system, which might explain the um, negative and cognitive symptoms of this illness. So the current thinking is that there might certainly be a mesolimbic dopaminergic excess, which causes psychosis. But then there might be a mesocortical dopaminergic deficit, which might explain cognitive impairment and negative symptoms. So then the question you might ask is, how come this person has two independent problems with dopamine? Excess lower brain region dopamine and diminished cortical dopamine. Answer for that is straightforward, which is that the mesolimbic and the mesocortical dopaminergic systems are inversely related, reciprocally related, due to a regulatory system that comes from the cortex to the midbrain regions, which is glutamatergic. So if there is a failure of the glutamatergic regulation, that might lead to an imbalance in the cortical and limbic dopamine, causing the symptoms of schizophrenia. Then you might ask, why is the glutamate overactive? That may be because it is normally held under check by GABA, the inhibitory neurotransmitter. And if the GABA is impaired, that might tilt the balance towards a hyperglutamatergic drive, which in turn leads to dopaminergic dysregulation. So the chemical imbalance in schizophrenia may be related to dysfunctions in multiple neurotransmitters, including glutamate, GABA, and dopamine. More recently, it has become even more complicated because there is another neurotransmitter, which I'll talk to you a bit more later. Acetylcholine might be involved as well. So the brain's dopamine may be kept in balance by the cholinergic activity as well. So it's getting more and more interesting and complicated. But this is the summary of the neurochemistry of this illness as far as we understand. Then the question might come up as to how I talked about synaptic pruning and I talked about the dopaminergic alterations. What might be causing these problems? So that gets us to genetics. Schizophrenia is a highly heritable illness with heritability of about 70 to 80%. And this is what you call a Manhattan plot, where you have each of these buildings, the different skyscrapers in Manhattan, being reflected with the horizontal scale being the different parts of the genome. The different buildings are the different genes and their polymorphisms. And the height of each of these is the degree to which they are abnormal, the significance threshold to increase risk for schizophrenia. So in the genetics world, a p to the negative zero point 0.8 numbers, 0.000, kind of eightfold p-value, if whatever exceeds that is considered to be significant over the entire genome. It's called the genome-wide significance studies. So genome-wide significance studies, or GWAS, have shown that there are currently about 350 plus gene locations that are implicated in schizophrenia. Interestingly, one of the most strongly implicated genes is in the sixth chromosome. It's like the Empire State Building there. And there are a large number of them, the others, that are also highly significant. And what has been found is that one of the strongest loci underlying risk for schizophrenia is in the complement pathway. Remember, I talked about complements, which are involved in synaptic pruning. So that's where these genes might appear. And interestingly, brain developmental and glutamatergic genes might account for about a third to a half of all the other genes that are implicated in this illness. Dopamine is only one of the 350 plus locations, but it is like a minor player when it comes to genetic risk for schizophrenia. So this is the hyper expression of complement C4 protein, which was found as underlying the risk for schizophrenia. But to be fair, it may still explain only a small proportion of the risk for schizophrenia. But here we have an example of how you can connect from symptoms and signs through the synapses to the underlying genes. But as I said, there may be multiple causal factors in what we call schizophrenia. There may be some rare genes of large effect, like the complement genes, or the 22q deletion genes, and so on. And there is a large number of small effect genes, which are common. And then the majority of the causal factors in schizophrenia may not even be understood at this point. Multiple environmental factors and gene environment interactions. So there may be neuroimmune mechanisms involved as well. Paulo Lozano in our group has been showing that there are alterations in immune molecules like interleukins, and also the structure in the brain that produces these immune molecules like the choroid plexus is hypertrophied in people with schizophrenia. So then you might ask the question, how does the synapse loss and cortical thickness reduction cause the disability? The synapses, the process that really keeps our neurons functioning is neuroplasticity. The neurons that fire together, wire together. As you see here, the neurons, when they connect with each other and they fire together, they produce an action potential. And that is what leads to neuroplasticity. And if there is a failure of neuroplasticity due to the synapse losses and the glutamatergic abnormality, that might underlie the risk for schizophrenia. Urvaksh Mehta, who worked in my lab as a visiting faculty some years ago, he did some work he continues to work in the area of measuring brain plasticity using using transcranial magnetic stimulations. So let's think about, you talked about symptoms and signs and brain structure and function and the synapses and plasticity. How might all that actually cause the symptoms? So that gets us to think about brain networks. The brain is a complex wiring diagram, and there are different networks. It works as like a networks, and the best way to understand psychiatric disorders is to understand them as dysfunctions in different networks. In schizophrenia, there are some networks that are particularly abnormal, and one particular network is what we call the default mode network. That is the part of the brain that gets activated when you're doing nothing else. This is also called resting state networks. What's been found in schizophrenia is that the resting state networks, the default mode networks, are dysregulated. They're kind of hyperactive. And schizophrenia also has a diminished activity of another kind of networks, which are called task networks. When you're actually engaged in a task, solving a cognitive problem, you activate certain brain regions like the dorsolateral prefrontal cortex, which is the task-based network. So there is an overactivity of the resting networks and an underactivity of the task-based networks. So what is it that switches the brain from a task activity to a default activity? There is another third system in the brain called the salience network. If you think something is important, you turn that network more. For example, if you think solving a problem or solving a cognitive task is the important thing to do right now, the salience mode switches brain activity to the task network. But if the brain is unwilling or is focused on something else that appears important, maybe someone out to hurt you, or some worries about what other people are talking about you, that switches the brain to the default mode network. So the thinking is that salience network being aberrant might lead to a default mode network disinhibition, which might cause psychosis. And a failure of the task based network, like the attention executive network, and also the reward pathway, which is the reward network, they lead respectively to the cognitive and negative symptoms of this illness. Keep this in mind because we'll come back to these when we talk about treatments. Another area that we've been very interested in is to answer patients' questions to us. They frequently ask. We say that you have schizophrenia today, and next year they come back, we have schizoaffective disorder. And, some years later, they say you have bipolar disorder with psychosis. So we are all over the place. Our diagnoses are not reliable, they're not stable. So we have been thinking of this from an agnostic perspective. Can you take a whole group of psychoses and look at their biology, biomarkers, and see whether you can actually reclassify these disorders in a different way? And that is what led us to a large study called the BSNP study, in which we identified, using machine learning based on biomarkers of electrophysiology and eye tracking and ERPs and so forth, into three broad categories, which we call biotypes. Biotype 1 is characterized by significant cognitive impairment and a diminished response of neural structures to salient stimuli. Biotype 2 seems to be like a noisy brain, overactivity of brain circuits to stimuli. Biotype 3 seems like it's very similar to normal, healthy people. And we have been looking at how we can validate these. And we, for example, showed that the biotypes differ in their hippocampal volumes, for example, as Cynthia Guimond showed here. Biotype 1 has the most prominent hippocampal alterations, and biotype 3 does not show almost any changes at all. Sinead Kelly, who's now in England, and no, she's back in the US, she showed that the biotype 2 has increased levels of brain inflammation. So I won't go into too many of these details. This is a body of work that requires a full hour, but suffice it to say that we may have other ways of classifying psychosis than simply based on symptoms. Now let's go into treatment. I won't go bore you with the details of antipsychotics. We all know about the first and second generation antipsychotics, and you have the second generation, and I'm sure all of these are available in the UK as well. But my main point is that there is a whole range of medications that are now available, over 70 plus antipsychotics. And I'll say a little bit about what may be one of the first antipsychotic that works a little bit differently. They not entirely be outside of the dopamine model. The cholinergic agonist which is xanomeline trospium. I'll talk about that a little bit later. And these drugs come with different kinds of side effects, which I won't go into too much into the detail at this point, but very briefly, first generation drugs, which are predominantly dopamine blockers, their main problem is extrapyramidal side effects. Second generation drugs, which are dopamine and serotonin antagonists, they produce metabolic side effects, some more than the others. And then the dopamine partial agonists like aripiprazole and brexpiprazole. So they have a somewhat different mechanism of action because of the partial agonist effect. They may have some superiority or some less likely metabolic side effects and may have some superiority in addressing negative symptoms and so on. Moving on to early intervention, as I said earlier on, the disease which we call schizophrenia and the spectrum disorders, they begin in adolescence, and in many individuals, there are what we call prodromal symptoms that go back to adolescence. In recent years, there has been a tremendous increase in interest in studying this prodromal population to see whether interventions could begin early itself to prevent psychosis. And if you follow them up over the course of time, individuals in the prodromal phase, the so-called clinical high risk, they have a probably about 20% chance of developing psychosis over the few years, three plus years after the initial emergence of prodromal symptoms. But important point to remember is that the other 80% don't, have a great life. Nearly 50% have not developed psychosis, but have some other psychiatric disorders, depression, anxiety, substance abuse, and some have no diagnosable psychiatric disorders, but are still not functioning well. Only a small percentage, probably about 1/6 of them, are completely okay at the end of during the follow-up period. So, which is what highlights the importance of early intervention. Initially, atypical antipsychotics were used, but they have side effects, and those side effects may make them not the most desirable intervention in the prodromal phase. But psychotherapies like cognitive behavior therapy and family focused treatments may have modest benefits. And cognitive remediation is also a potential intervention, but not enough long term studies on those. One thing that has been observed over the years in the Naples study, which is the prodromal North American longitudinal study, is that you can actually predict conversion to psychosis by using a calculator that is made up by early prodromal symptoms and risk factors. We have also looked at a similar calculator to predict psychosis in offspring at familial high risk for psychosis. So now it may be possible to develop some level of an objective prediction of psychosis risk, just like those who walk into the emergency room with a chest pain, there are calculators that can predict the risk of the next heart attack and so on. So similarly, psychosis may be predictable. That takes me to what about after the first psychotic episode has emerged? So there is the landmark study that was done in the US a few years ago called the RAISE study, which made the point that outcomes are better if you use a coordinated care in the beginning phases of the illness combining multiple elements of intervention, including psychotherapy, psychopharmacology, substance abuse treatment, supported employment, integrated medical and health, behavioral health care, cognitive remediation, and peer support. So, a coordinated care by a team may be superior to treatment as usual. And that was indeed shown in this kind of complex slide by John Kane, showing that coordinated specialty care was superior to treatment as usual in improving outcomes, improving quality of life, and also total symptomatology. So multiple elements of outcome were better in the coordinated specialty care limb of this. This is a meta-analysis of several studies that around the world that compared these interventions. Moving on to treatment resistance, about a third of people with schizophrenia don't respond to standard antipsychotics. And that is where clozapine comes in. And clozapine is effective in probably about two-thirds of that one-third who don't respond to standard antipsychotics. At this time, we still don't know how clozapine works. It's certainly like a Swiss Army knife. It has multiple effects, including not only dopamine, a weak D2 effect, but more D3 and D4, serotonin, and muscarinic cholinergic effects. So, and also we don't know in whom it might work and in whom it might not work. There are a lot of side effects, so you don't want to give it to everybody. You want to be able to be selective in choosing the right patient for clozapine because it has its problems. We still need to do a weekly blood test, at least in the first few months, and to prevent agranulocytosis that can be serious and fatal. So, with that in the background, we have been studying the brain physiology to see whether there might be a subgroup that are particularly better responders to clozapine. We still don't have the final results of this, but what we have found is that the subgroup, which we call biotype 1, characterized by diminished neural responses to stimuli in their evoked response potentials, might be the ones that respond to clozapine better. It's an ongoing study, so I won't go into too much of the details of this at this point. So the next thing I want to talk a little bit about is what is it that underlies functional impairment in this illness? As I've said before, cognition is a fundamental problem, and dopamine blockade doesn't do much to improve cognition. So for that reason, several other lines of work have been tried, including the glutamatergic modulators, GABA modulators, cholinergic modulators, and so forth. But unfortunately, very few of them have demonstrable effect on improving cognitive deficits in this illness. As I said earlier, cognition is a function of brain plasticity. The more the neurons wire together, the more neurons fire together, they wire together. And that principle is exploited by the psychosocial approaches such as cognitive remediation, which involve training the brain. The more you train the brain, the more you put those neurons to work, the more they wire together. And that has led to the idea that cognitive enhancement therapy or cognitive remediation might be the way to go in terms of recovering from moving individuals with schizophrenia towards recovery to improve their cognition, improve their functioning. So we have developed a an approach called cognitive enhancement therapy, which we have done 3 independent randomized controlled trials, all of which show superiority compared to control interventions. And we are in a 4th study, which is a community-wide implementation. This is a 1-year long treatment, weekly sessions with neurocognitive uh, training exercises of the computers, and group therapy and individual therapy focusing on social cognition. And these are the 3 independent randomized controlled trials that we have published showing superiority of CET over control interventions. The left of each of the bars for each of these is CET, and the right is control. As you see, there are effect sizes, fairly significant effect sizes, to improve neurocognition and social cognition and processing speed. And these results seem to be durable if they follow through the 1 year treatment. And we have been progressively developing interventions that are shorter, more feasible. This is what our current study is trying to do. We have found in those studies that not only do they improve cognition, but also the cortical thickness, and specifically brain regions like the hippocampus and the fusiform gyrus increase in those who are treated with cognitive remediation. And the more they change, the brain changes, the larger is the improvement in social cognition. And this is our currently ongoing study funded by PICORI, which is across 15 different sites in the United States. Another important field is exercise, and we've been developing a virtual reality based approach to combine cognitive remediation and a physical exercise so that you get 2 birds for one. And so it's in a very early phase. Another approach to improve cognition is sleep. We all know that if we have a good night of sleep, we are able to function better the following day. And overnight, our brain consolidates memories and sharpens the brain. And this is based on this is related to a particular kind of oscillation in the brain called spindles. And these spindles are in the non-rapid eye movement sleep, stage 2. And one way to strengthen that is to give neuromodulation to the brain, the deeper parts of the brain, and that can actually enhance spindles and thereby may improve cognition. So that's an ongoing study. We bring patients in to take a nap in our lab, and during the nap, we do TDCS, transcranial direct current stimulation, to see if that would improve cognition. Again, we don't have the results for this yet, which is kind of underway. We have some preliminary results, but and there are other groups which have published data as well of neuromodulation enhancing cognition by stimulating sleep-related spindle oscillations. Another approach to enhance functioning and cognition is to use smartphones for people to do cognitive exercises in their free time. John Torres has developed a platform called MindLamp on smartphones, which can track symptoms, cognitive functioning, sleep, and physical activity levels, and put them all on a common dashboard so that we can monitor how people are improving on a day by day basis. And using a digital navigator, a trained clinician who can help them with the smartphone app, you can actually track and also get patients to participate in digitally based psychotherapeutic interventions. This is John Torres there. So this is a like for a test, a trail making test, which is a cognitive task that we can do. And this is an example of multiple tests that can be used on smartphones. Roscoe Brady in our group has been um, doing neuromodulation using transcranial magnetic stimulation. And he is pioneering a concept of circuit based treatments. So he found, for example, that negative symptoms in schizophrenia are related to a dysfunction of the cerebellofrontal pathway. And by selectively stimulating the cerebellofrontal pathway, he showed improvements in negative symptoms. So this work is ongoing, and he is extending that to address psychosis as well as negative symptoms. Now, coming to pharmacology, as I said earlier, the field is still with dopamine, and all our drugs, with the possible exception of xanomeline, work on dopamine. So it's like the story of Mullah Nasruddin, where he's looking for a key under a light and a lost key. And when someone came and asked, Why are you looking for this key here? He says, because the light is better here. So just because we know more about dopamine, dopamine is the one where everyone is looking for answers, but the real keys for improving schizophrenia might lie elsewhere. So that brings us to other ways of um, modifying the synapse to develop better drugs. Of course, anti-dopaminergic drugs is what we have, but it may be possible to modulate glutamate using drugs like glycine, deserine, evenamide, which I'll talk to you in a moment, homoglometard, which is a Lilly compound, sodium benzoate, and so on. Nicotinic drugs, and muscarinic drugs, serotonergic drugs. So there may be multiple pathways to modifying the synapse. I'll take you through a few slides with each of these. Glutamate, which I won't go into too many of the details about the glutamatergic synapse, but suffice it to say that there are multiple ways to modulate the glutamatergic system. Many drugs have been tried and tried and failed. Even though, as you saw earlier in my talk, that glutamate is very important for brain plasticity and may be abnormal in this illness, there is no glutamatergic drug yet for schizophrenia. Bitopertin, a glycine transporter inhibitor, recently failed. Glycine effects may be modest. Sodium benzoate is still at very early level. Pomeglometard, which is a mGlu metabotropic drug, initially was a lot of excitement, and then a subsequent study did not replicate. So there is a lot more work to do. One drug that is particularly interesting, which is now moving into phase 3 trials, is evenamide, which is a sodium channel inhibitor, which also reduces glutamate release. Remember the earlier slide where I pointed out that a disinhibited glutamatergic system might underlie psychosis. And if you retune that with drugs that reduce glutamatergic release, such as evenamide, there might be a way forward. Serotonin has been an interesting pathway. There's a drug called pimavanserin nuplazid, which is approved for treating dementia-related psychosis, but does not work in schizophrenia. Cholinergic. This is where it gets a bit more interesting. I don't know whether xanomeline is available in UK yet. It was approved last year in the US, so we're beginning to get some experience with it. Xanomeline, which is a muscarinic agonist, has its own side effects of the cholinergic side effects. So cleverly, the company combined that with a peripheral anticholinergic, just like you combine L-DOPA with carbidopa, combine xanomeline with trospium, and then you have a drug that has a less side effect burden. So time will tell us how much it will play a role in schizophrenia treatment, but at this time there is a lot of enthusiasm about it. Nicotininergic drugs have not really panned out that well, like ansenecline, which did not work. Um, and there are other options. Phil McGuire has been investigating cannabinoids like cannabidiol, which may have some positive benefits in psychosis symptoms. There are another group of drugs called TAR agonists, traceamine receptor agonists. Unfortunately, a major study, the phase 3 study, did not pan out, did not work. The drug was Lotarant. Oxidative stress is implicated in schizophrenia. Antioxidants like N-acetylcysteine may work in some individuals. Anti-inflammatory drugs, minocycline, maybe even metformin, might have a role to play. Now, before I finish, I want to end with a brief note on mindfulness-based meditation approaches. Remember, I showed you the network model of schizophrenia, where there might be an overactivity of the default mode network and an underactivity of the task mode network. There are different types of meditation. Broadly, there are two types of meditation: those that involve focusing the mind, like focusing on a mantra or a rosary or a flame. Schizophrenia patients might do well on that because you're helping them to train their task mode network to function better. There is another kind of meditation which is called open monitoring, where you let the mind wander freely, but of course under guidance. Initially, some patients might psychosis might actually get worse with this kind of an open monitoring approach. But if used with good coaching and training by a yoga or a meditation practitioner, over the course of time, it may be possible to help the individuals to self-regulate their own default mode network and thereby reduce psychosis. So it's all work that is to be done, and some of it is in progress. Valbenazine has been recently approved for tardive dyskinesia. It's it works like reserpine by working on the presynaptic vesicles, whereby it depletes neurotransmitters like dopamine. So that's just one new direction in the field. And finally, I want to initially I said that the um, the diagnosis of schizophrenia and schizoaffective disorder, they keep changing, and they don't have much biological validity, but they have another problem of stigmatization. And we recently asked a large group of multiple stakeholders, including patients with and family members and frontline clinicians, and 74% of them said that they don't like the word schizophrenia. They would rather prefer something that has a brain in it. So this is where again more work is needed to understand what is the nature of this entity, what is the underlying disease process, and can we have a more non-stigmatizing name for it. So in summary, schizophrenia results from an exaggeration of synaptic pruning during adolescence, may be related to deficits in brain plasticity. Dopamine is certainly important, and there may be um, other neurotransmitters that are involved as well. Multiple genetic and environmental factors may interact to produce alterations in brain development, synapse integrity, immune and channel mechanisms. And these brain abnormalities might cut across symptom based diagnoses, and there may be a more biological way of classifying schizophrenia into subtypes, which may have distinct treatment outcomes. And future studies might include glutamatergic, GABAergic, and cholinergic agents, anti inflammatory and antioxidant agents, targeted neuromodulation, and also psychotherapy. And schizophrenia remains highly stigmatized, and there may be a time to change the name. Of course, it requires better understanding of the concept of this illness. So I want to thank you. There are many foundations and grant support that I want to acknowledge, and also or my group that works with me over the years. Thank you all.